You make me blush. No, it's nice to be here. Thank y'all. I'm the pediatrician, founder of Peds MD, which is I call it a boutique house calls practice. I'd go old school. So I see kids in their home, which I'll talk about really helps when it comes to airway assessments, which may sound a bit strange. But more importantly, I'm the father to two kids. I have an almost 5-year-old, almost 3-year-old, or as my wife would say, a 4 and 2-year-old. Their birthdays are next month in January, so I think it's safe to just go ahead and call them 5 and 3, but I'm aging them too fast. So anyways, we're gonna get the slides up. So I'm here to talk about something that I know keeps a lot of us up at night. I know keeps me up at night, quite literally, or keeps our kids up at night. And that is the pediatric airway, or airway issues, I should be more specific, and sleep disturbances. So when we see a kid that's mouth breathing, when we see a kid hear a kid is snoring, our mind always goes to the usual suspects, right? We hear a lot about tonsils, adenoids. We heard a lot about mouth structure. I learned some stuff about mouth and the actual dental structure. We think about things like this, right? And in many cases, that's where the problem is, right? But what happens if you fix that issue and the kid still has problems? The parents are still saying that their kid is restless.
I didn't get that.
That their kid is... Do you have it? Let me see. One second now.
All the ones we have.
No, I don't. No, I don't see it.
Oh no.
Yeah, just ask them. I can keep talking while. Yeah, I know all the slides. It's fine. Sorry, y'all. They're going to try and find the presentation. But so what we're diving into is when the kid isn't better after we make that intervention on what is usually a structural problem. We're going to dive into the medical reasons that these kids could still be having issues. Okay, and so. That's what, again, we're diving into today is the medical conditions that go beyond the structure. And so I'm gonna show you some things that I think will surprise you, and hopefully we can get the slides up so I can have y'all follow along there. But let me first tell you what we're gonna accomplish in the next 20 minutes or so. First, I'm gonna show you how the actual house calls model really lends itself to helping identify these airway issues, identify major sleep disturbances in kids, and then how, again, doing these house calls, being in the home, actually almost like a private investigator, Dr. Capitan said last night, almost like being a private investigator really helps us to identify these problems and obviously intervene. The second thing we're going to do is actually the meat of our talk, and that's where I'm going to share with you 4 different medical reasons that kids can have airway issues and therefore sleep disturbances. And so the first one is actually something interesting. It's actually their iron status. It may seem crazy to be talking about iron, but iron status is really, really important when it comes to sleep. And also there's a connection with the airway as well. The second thing, we've already been talking about upper airway inflammation, tonsils, adenoids. We're going to talk about that with a little bit of a medical twist. The third thing also surprises a lot of people is gut health. Something that kind of, a lot of pediatricians don't really spend any time talking about, but there are direct links between gut health and sleep, and actually the airway as well. And then the last thing, really importantly, is the ADHD sleep connection. So that's really important. The third thing we're gonna learn in the next 20 minutes or so is kind of what we heard, just a different option for screening for these issues, right? Because all of us are busy, right? We don't have a lot of time, and so I wanna try and give you all some practical things that you can take away, use not tomorrow, but Monday, unless you work weekends, but things you can use on Monday to help identify for these issues and not to solve them, but to actually just have conversations with our parents about these issues. So, did you get the slides?
Yep.
And I know I'm the only thing standing between y'all and lunch, so I'm gonna make sure I stay on time, don't worry. Okay, so while she's still working on it. So why should we care about this? Who here has kids? Right? And pretty much everybody in the room has kids. Poor sleep in kids is much more than just them being tired the next day, right? Oh, we have slides. Yes. Thank you. Awesome. Okay, thank you so much. So poor sleep is, again, much more than just about, oh, they're just going to be tired the next day. No. It is much, much more than that, much more. We're talking about disrupted neurocognitive pathways during some of the most critical growth phases of their life, right? Their brains are literally being built as they sleep. And if that sleep is disrupted by breathing issues, then we're messing with the very foundation of their development. It's that important. Chronic airflow disruption really affects everything. It affects, it doesn't matter what it's from. It could be obstruction, it could be inflammation, which I'm going to talk about. It could be restless sleep, which I'm also going to talk about as well. But it affects everything. You're talking growth hormone release. We're talking behavior regulation. We talked about crazy kids, right? Behavior regulation, right? Those crazies probably aren't getting good sleep, right? I see it all the time in my practice. It affects learning and memory consolidation, right? How our kids are actually learning, IQ, it can impact that as well, right? We just heard about that. And they can also mess with immune function. So it literally can make our kids sicker, right? So these are all the things that chronic airflow disruption leading to poor sleep can cause. And here's what keeps me up at night, is that if we identify this, we can treat it. We can treat it and we can prevent long-term complications. So if we're only looking at the structure, which is important, we don't want to take any of that away, we're missing a huge piece of the puzzle, which is the deeper medical issues with what's going on. So before we dive into the medical conditions, I want to acknowledge the elephant in the room. Why aren't we screening for this in our pediatrician's offices? Why aren't we doing it? It's a lack of time, right? It's become a DMV, frankly, DMV experience. Probably in a lot of your offices too. It's just all about, I like the drill and fill, that's a cool term. But it's just about volume, volume, volume. So it's about, we just don't have time, right? There are so many other priorities. I know for me, when I worked in a traditional practice, I'd see up to 30 kids a day, right? And in a 10 to 13 minute visit, I have a huge list of things Bright Futures wants me to cover. I have to do an exam, I have to document, right? AI's helped with that, but I have to do all these things, and at the bottom of the list is gonna be sleep, right? So the reality is sleep histories, detailed sleep histories get deprioritized. Parents don't bring these up as issues unless A, their kids are keeping them awake, or if it's really severe. And so these things often go unnoticed. And even if it is brought up at these checkups, our pediatricians don't have time to coordinate with specialists or can't follow up really proactively with these families to actually make an intervention. And so it all boils down to time. And so a quick pitch, I promise this is not a sales pitch. A quick pitch for just how the concierge model really helps us. I can spend time with families, and concierge practices, DPC practices, whatever term you want to use. We get to actually spend time with patients to actually dive into these issues and ask questions. And when I'm in the house, I can even ask the parents, like, show me where they sleep. I want to see their bed, right? Because no kid wakes up and just throws all their sheets and blankets all over the place, right? I can physically see how they're sleeping, and I can probably tell you, like, this kid's not sleeping well, right? So again, whether you're in a traditional practice or you have an alternative practice model, even if you don't have a lot of time, I'm going to talk about quick screening tools that you can use in your office. But the key is just really knowing what to look for. So let's dive into the medical conditions. So here's where it gets interesting. Talk about kind of some cool stuff, including the iron. So we're going beyond the structure. We're looking at some of the medical reasons. Again, we're not just thinking about tonsils, adenoids, nasal structure, the septum, the mouth, the face. We're not talking about just those things. We're talking about other things. So the 4 things we're going to cover are low serum ferritin. We're going to cover upper airway inflammation, kind of a rehash a little bit, more from a medical lens. And we're going to talk about gut inflammation and then that ADHD sleep connection. And again, these aren't separate silos. I'll talk in the end about how all these are really interconnected, which is really important to consider. So let's dive in. So let's start with something you may not really think about, like when it comes to airway issues, but low serum ferritin. All right, ferritin is actually a good measure of total body iron. And there's a stat that should really make you sit up in your chair. 75% of kids who have restless sleep have a ferritin below 50. Now, they're not anemic. Okay, we checked their hemoglobin. They're not anemic. Their hemoglobin's normal. But their brain iron is low. So what happens when your brain iron is low? You actually get something called dopaminergic dysfunction. And what that causes in kids is restless leg syndrome, something called periodic limb movement disorder, or syndrome, PLMS, other things. But the takeaway is that all night, these kids are moving and grooving, right? All night. They're tossing, they're turning, they're kicking, they're repositioning. It's constant, right? So here's the airflow connection that people miss. When you're constantly moving and repositioning during sleep, your sleep architecture becomes very fragmented. You're never getting that really deep restorative sleep. I know a lot of us probably use Aura rings or Whoops. You're not getting in those deep phases of sleep. And fragmented sleep disrupts normal breathing patterns. So what happens is these kids, due to nothing structural, I mean, layer the structure on top of it, but these kids end up mouth breathing because they're in lighter states of sleep where the respiratory center is less stable, right? So it's an actual medical reason for them to be mouth breathing. The amazing thing is, I think the most amazing thing, is that over 60% of kids have resolution of these symptoms with simple iron supplementation. It's simple ferritin check, simple treatment, but huge impacts. And so this is I want to start with this one because it's really important. Pretty much every member that I have as part of my practice has had a low ferritin level. So it's low-hanging fruit. The one that everybody knows, we spent some time talking about this. I know I'll probably spend more time talking about it today, but upper airway inflammation, so tonsils, adenoids. We all know these stats. 7% of kids habitually snore, 2% of kids have true obstructive sleep apnea. You know, those late toddler years are when the lymphoid tissue is usually largest relative to the airway. So all of this is direct obstruction, right? The classic obstruction that we see. Normally, what do these kids get told? Send them to ENT, we take out the tonsils and adenoids. It's simple, right? But this is important. Not all upper airway obstruction is just because of the structure of the tonsils and adenoids. Often, pretty much every time, the tonsils and adenoids are enlarged for a reason. And it's usually a reason that we can figure out. And so there are specific things. So like things you probably haven't thought about. So food sensitivities, gut inflammation can affect immune function and cause lymph nodes to swell, including your tonsils and adenoids. Mouth breathing from nasal congestion can make this all worse, can make the tonsils and adenoids swell even more, right? Because we're bypassing the body's air conditioner. So yes, sometimes the answer is let's take them out. But I know y'all probably seen this. How many kids where you take them out and they still have issues, right? That's because there's something more. So the takeaway from this slide is there's usually another layer to the onion you can peel back, and it's important to ask those questions. Now here's where it gets really interesting. So connecting gut health with your actual like airway and sleep. It seems really bizarre, but just stick with me here. I see a lot of misconnections when it comes to gut inflammation, but gut inflammation can really impact your airway and sleep. So let's start with the most common issue, which is actually dysbiosis. Everybody know what dysbiosis is? Heard that term before? So dysbiosis is basically an imbalance between the good and bad bacteria in your gut. Or it can just be you don't have enough bacteria in your gut. And so dysbiosis, there's some really interesting research there's a bunch of research that's showing the gut-brain axis that's really solidifying the combination or the connection between the gut and the brain. And specifically within that gut-brain axis, the actual if you have dysbiosis markers, it can actually affect your sleep. And they've all seen that works both ways. And so vice versa. And so I pretty much do stool testing on most of my kids, and many of them do have dysbiosis, and it's yet another thing that we can try to address and fix to help with their sleep. Food sensitivities and allergies. If you talk to most pediatricians, food sensitivities are like, no, I don't really put too much stock into that, and it can be tough. Testing, they have a finger poke test now. The testing can be hard to interpret, and you have to do elimination diets. It's kind of tough, but food sensitivities, parents often don't connect their kids' diet to their kids' sleep. And we talked a little bit about just processed foods, right? Food dyes, obviously that's getting a lot more attention now. There's things like that are more can directly impact your sleep. But this is specific to food sensitivity. So what can happen is food sensitivities cause inflammation. Part of that inflammation can actually be nasal congestion. And that nasal congestion can lead to mouth breathing, right? So you're going to, again, we keep talking about mouth breathing. It's sounding like a broken record, but we all know mouth breathing affects airflow dynamics, and it just continues to dry out the airway, and it's just a vicious cycle that we really need to break. And so the clinical pro here is when you have a kid that has sleep or airway issues, think about the gut. Think about constipation, diarrhea, abdominal pain. Think about eczema. Do they have eczema, right? Can you see it on their skin? Can you ask the parents about it? Do they have other atopic conditions, asthma? Because if they do have a lot of these things, usually that means the gut is in play and related. All right, last condition, and frankly, I think this one is criminally under-recognized, but it's the ADHD, sleep, and airway connection. So here's a stat that blows my mind, maybe not yours, but up to 1/3 of kids that have a diagnosis of ADHD have sleep-disordered breathing. I don't know about you, but that makes me question the rising amount of kids that are being diagnosed with ADHD, right? Because let's think about classic ADHD symptoms. Impulsivity, hyperactivity, they can't focus, right? And obviously this can affect lots of different things. But you know what else can cause those exact same symptoms? Chronic poor sleep from breathing issues, right? And so is it, and it's chicken or egg issue, right? Is it truly ADHD? Or is it just that your child's not sleeping well? It's hard to say. The clinical implication though, at least for me, and for y'all too, is when you have a kid that's diagnosed with ADHD, before I even start a stimulant medication, or sometimes I do it at the same time if they really need it, I like to screen for sleep and airway issues. Because often, if they have sleep issues and we optimize that, they can either they may not need medications, or they may need a lower dose, right? And so it's really important to recognize the relationship between the two of these. So here's where it all comes together, and this is why I mentioned at the beginning how all this stuff is all interconnected. And it's also why these cases are so complex. That everything we've talked about in this talk and in previous talks is all interconnected. Fragmented sleep leads to systemic inflammation. Systemic inflammation only worsens airway and breathing and gut symptoms. These worsened symptoms continue to disrupt sleep. And so it's this vicious cycle that most kids just cannot get out of, and most parents just can be completely unaware of, right? And this is why a multidisciplinary approach with all the people in this room is so important. I can't solve it on my own as a pediatrician. I need help, right? I can't do it all. And so that multidisciplinary approach is critically important. So we need, and you really need to address multiple contributors in parallel. So we need to assess the airway. We need to have kids obviously having regular dental checkups. We need to evaluate the ferritin in some cases. We need to be asking about sleep. We need to assess gut health. We need to check for ADHD. We need to do these things. And the beautiful thing is once you tend to fix one area, other areas start to improve. And so really, really important. All right, so you're thinking, okay, this is all great, but how am I gonna screen for this? This sounds awesome. And this, I promise I'll give you some fairly easy things to take away. But the first thing is the BEAR screening tool. Has anybody heard of the BEARS screening tool? Yeah, we've had a couple people. So the BEAR screening tool was developed at Boston Children's. It's validated, it's quick, it covers all the basics. You can see here bedtime problems, excessive daytime sleepiness, you have your night awakenings, your sleep regularity, and then also snoring, right? So this is a questionnaire. I'd have it just listed out in text field, but they have a parent form and a child form that they can answer themselves. Super quick form to fill out. Normally takes no more than 2 minutes, which I know is a lot of time for a lot of you, but 2 minutes tops. But the important thing is that this can help us identify those kids that are at risk. The other things you'll see here are questions, sometimes signs, symptoms that I see in kids. And so take a picture or look at those there. So a few just implementation tips or ideas, things to take back to practice if this is something that you want to implement. Having this as part of an intake form, it doesn't need to be done at every visit, right? That doesn't make sense. But having this as part of an intake form, having this in the patient portal can be a nice, easy way for parents to fill this out ahead of time so that you can review it in the office. Obviously, as anybody that works with kids, we're observing, right? We're watching the kids. We're seeing how they're breathing in the room, right? So that's important too, that observation piece. And then if anybody's ordering labs on kids, pre-op labs or et cetera, adding a ferritin, right? It's like just a very simple thing you can do to capture those kids that have that lower ferritin. So let's bring it home, because I know it's almost time to eat. So I know there's 4 points here, but I have 4 key takeaways. One is think beyond the structure. That's obvious, right? So ask questions. The structure is important, right? Don't take that away. The structure is very important. But I would argue some of the things we've talked about today are equally as important, potentially more important, depending on the kid. The second thing is that all these conditions are interconnected, and it's really important to have that multidisciplinary approach and that team. The third is that simple screening can help identify these kids. And the last thing is that early identification and intervention can help prevent these long-term complications, things like growth issues, behavior issues, potentially setting kids up for poor school performance, et cetera. So that's the message I want to leave you with today, is to be curious, to ask questions, because these kids, our kids, are all relying on us. So thank you for sitting through my 20-minute presentation. Happy to, I think we have some time, so happy to take some questions, and then I'm going to be here for lunch. So if y'all want to chat more about any of this stuff or more about my house calls model, I'm happy to chat with y'all. And then, yes, you can. This is my number that all my patients use. You can text me. I don't mind. Yeah.
How long would you attempt to remediate things like iron deficiency, ADHD, before moving on to the
Yeah. Yeah, so it's how long would I guess, be treating, iron or iron deficiency or ADHD symptoms, I think you said before, moving on to other things. So it's a very good question. It really depends. So I take a very individualized approach with every one of my patients. And some of those questions I had, or under the VAERS questions, help me figure out where I want to start first, right? So serum ferritin I pretty much recommend for all my patients because it's straightforward. Normally, if I'm getting blood, there was a finger prick test that I got from Europe that tested for ferritin, which was really nice. The company stopped making it, which is a bummer. So now we have to go back to drawing blood, which does, it's not ideal for kids. But and sometimes for some kids that have a lot of anxiety, I'll just start them on iron, right? Not the high dose like low dose, but normally I try for at least 3 months. ADHD is usually a bit quicker, and some kids, if they're in school, and their inattentiveness or hyperactivity is disrupting their ability to actually focus on school, I may start medications while we also work up other things, assess their sleep. That's what I was saying. Sometimes you kind of have to start medicine if they really need an intervention. So, but no, I would say normally at least a few months. Yeah.
I have a question. Would you share with everyone, since the majority of the room isn't in the pediatrician field, the labs that you would typically run on a patient, because a lot of families would find it to be a barrier to care if they go to their pediatrician and they say, hey, a pediatric dentist suggested that there may be some deficiencies that we should look at. I think that there's a high probability a pediatrician may brush that off, versus if the pediatric dentist referred back to the pediatrician and said, I'm requesting these labs. So that we can evaluate X, Y, and Z things. Then maybe having that list.
And again, that's that multidisciplinary approach that's lacking, right? It just is, and it's due to a lack of time, right? Pediatricians don't have time to do that stuff, honestly. Again, it's sad, but it's just the truth. But I order pretty much a standard panel when I'm drawing blood. I try not to. I don't just get a ferritin ever. We usually will get at least a CBC, a CMP. I like to get thyroid function. So sometimes I'll add different things depending on the kid. Like last week I had a strong family history of autoimmune disease, so I added on some autoimmune workup because mom asked. So sometimes there's some specialty stuff that I order, but it's usually kind of the same bag of things. Yeah, but that's what's missing, right?
Why do you think that ferritin level is so low on patients you're looking at?
I think it's a very good question. The diet, I think, is the biggest thing. One of the problems with ferritin, it was on my slide, is that the normal range, I think, I'm trying to remember, LabCorp's lower end of normal is like 20. So anything above 20 is flagged as normal, right? But all these studies have shown really it needs to be 75 to 100. And so I think, if you ask me, I think it's more diet related than anything else. There's probably lots of other factors, but that's probably the biggest one. But every kid, pretty much every kid I've tested has been below 50.
That's great stuff. Thank you, Trey.
Of course, yeah.
Applause, but